Hello, everyone. And thanks for joining us on this Facebook Live. My name is Shannon Hartley. I'm the Chief Marketing Officer and Program Officer for Shatterproof. And today's event, which is sponsored by Pacira Pharmaceuticals and The Choices Matter, which is a campaign that's designed to educate and empower patients to ask questions of their doctors about non-opioid alternatives for surgery. I'm really excited to be joined here today with two very special women. Dr. Alyssa Dweck is an author, a women's health expert, and a practicing OBGYN with over 20 years experience, and she's also the mother of two boys. And Kim Robbins is a Shatterproof Ambassador, a veteran, a peer recovery coach, and has made it her mission to really educate others about the topic of addiction. And she advocates for better access to non-opioid options. And she is also the mother to 6 children, which we've said we're very impressed by. So thank you both so much for joining today. I think this is going to be a really great discussion. So we're going to start with some questions, just to have a discussion together. But for those who are watching, please submit your questions. At the end, we want to make sure we have a chance to answer your questions as well. So we really appreciate you joining us. So as we get started, I know we see every day in the news the continuing tragic information about the opioid crisis. Last week, the CDC released the latest data about the number of opioid overdose deaths. And clearly this is an epidemic that is affecting everyone. This does not discriminate based on geography, income, gender, race, hometown. I mean, it really is impacting across the board. And the fact that we're seeing this and hearing a lot about it, but a lot of times in the statistics, what gets lost sometimes are the stories and the personal impact. And I know I'd like to start with, for myself, also a mother, a personal experience I had last year when my teenage son needed to have his wisdom teeth out. And as he went, very common procedure, and as I spoke with the oral surgeon about, are there any non-opioid alternatives? First he told me no. He told me that my son was going to be in a lot of pain and I needed to just be a good mom and kind of get ahead of the pain. But he handed me a prescription for over 30 Percocet for just a simple wisdom tooth extraction. Now, fortunately, I work in this area, so was able to push back, was able to really think about, I didn't want my son to be in pain, but I also recognized the really startling statistics that the younger people are exposed to opioids, the more likely the opportunity to become dependent and addicted to these medications. Now, fortunately, my story had a very happy ending. I did not give my son the opioids. We managed his pain with Tylenol, a lot of milkshakes, and ice, and he was back on the lacrosse field in a couple of days. But too many people don't have that experience, and that this can be a real gateway for people to become exposed to opioids and become dependent or become addicted. So Kim, could you start with, tell us a little bit about your story and how this impacted you?
I was injured in the military and broke my hip, and I had a total hip replacement. Immediately after surgery, I was given opioids, and I really liked the feeling of them. And I was looking at the clock like, when can I ask the nurse for the next one? And a year later, I was still taking them. And I realized I'm addicted. If I would stop taking them or miss them, I would start feeling the withdrawal symptoms. And so I knew I had to do something about it. And I was looking around trying to find somewhere to go to get help. And there was a waiting list, and there were no resources for me. So I ended up going to the ER and then just going through withdrawal on my own at home. It is something I would never want anybody to go through and experience. And I decided to start talking about it, sharing my story. There was a lot of shame at first. I didn't want to talk about it. I was embarrassed. But then I realized if it was happening to me, how many other people is it happening to? So I started talking about it and advocating for non-opioid options. And I just started a nonprofit organization to offer free recovery life coaching.
Excellent. And as you said, your story is all too common. As you started talking about it, did you find other people would open up and you would hear that others were experiencing this as well?
When I started to share my story, people would come up to me, and I'm in recovery also, and they just never talked about it. It's something they kept to themselves. And I think that if more people shared their story, we could change the stigma of addiction.
Absolutely. And I'm sure as many people or followers who are maybe watching know someone with a similar story who've been prescribed opioids, who may have become dependent, but also just prescribed opioids to manage pain. I mean, these are good drugs. These aren't bad drugs. These are good drugs that have an important purpose. But as we talk about, it's that ongoing use. In fact, a recent study found that 9 out of 10 patients receive opioids to manage post-surgical pain. And a new study that report by Choices Matter found that patients are receiving 100 to 200 opioids to help manage post-surgical pain from common procedures like hip replacement, like knee replacement, rotator cuff repairs, or gastrectomies. Another procedure that many people are having, I know this was a surprising statistic to me, is that C-sections are the most common inpatient surgery in the United States, with 1.3 million procedures performed a year. It's a lot of C-sections. And according to a recent study, women are often prescribed more opioids than needed following that C-section, and it really can create a high risk for addiction or dependence. Dr. Dweck, can you explain how is C-section pain traditionally managed, and is it possible that we can reduce the number of opioids that women are exposed to for C-sections?
Right. I'm so glad we're talking about this in the sense of women's health and C-section and childbirth in general, because oftentimes childbirth is the first entree into when women may be prescribed a narcotic medication. And look, no medical care professional wants anyone to suffer in pain, but I think it's really, really important to manage expectations exactly. We need to educate our patients and let them know there's going to be pain, this is how we're going to manage things, and set them up for a realistic course. So what we normally do during a C-section, particularly if it's planned, is plan on something called regional anesthesia. Spinal or epidural, where women are awake and they have their faculties about them, but they are comfortable from the waist down. And as surgeons, we take it upon ourselves to use whatever alternatives we can to opioids to manage pain. So for example, I will often use an injectable, long-acting anesthetic at the closing time of a C-section procedure. This will minimize the need for opioids after the fact. And sometimes this can have an effect for even up to 2 or 3 days, so we really can get people through the hump of uncomfortable symptoms and then get them started on oral medication that is non-opioid. I rely heavily on other alternatives. A favorite of mine is called ketorolac. Some of you may have heard of it called Toradol. This is again a non-narcotic medication, an anti-inflammatory, very helpful for pain and not habit forming. And it comes as injectable or oral, so we have an opportunity to use it both during and after the fact. Excuse me. And then in addition, the acetaminophen, Aleve and Motrin and Advil alternatives, these other non-steroidal anti-inflammatories, are mainstay treatments for pain control.
Excellent. And I think you really highlighted the importance of thinking about and talking to patients in advance of creating a pain management plan. Can you talk a little bit more about what that conversation looks like with your patients?
Absolutely. Look, we're lucky when we have the opportunity to have an advanced conversation about C-section or delivery. Oftentimes we're faced with more of an emergency situation and that conversation may be a little bit abbreviated. However, yes, women need to understand what their options are for pain control both during delivery and afterwards. And women go to great lengths to create birth plans for everything from what kind of vitamins I want my baby to have to what type of prep I want on my belly or whatnot. So pain control is huge and needs to be included in this conversation. So we often will speak about regional anesthesia and these alternative medications for after the fact. I want to make something clear. I think that, we don't want people to suffer in pain, but we often get a lot of information knowing how much pain somebody is in. Women also want to be present during childbirth, for sure, where they want to be able to bond with their babies. They want to be able to initiate nursing right away. They want to get up and get back to their lives and feel like they're able to care for themselves and their baby and maybe other children. So it's really important to avoid these medications if possible.
Thank you, that's really helpful. And you talked about, and Kim, you mentioned that when you had the surgery, you were immediately given lots of pain medications. I know in my example, my son was, the first prescription was immediately, here's a prescription for pain medication. Can you talk a little bit about, are surgeons feeling pressure to prescribe more opioids than are necessary to treat patients? Or how do you find that kind of balance of when it's appropriate to use them and how to manage that?
That is an excellent question. And I think this whole opioid epidemic has been a big wake-up call to healthcare professionals and lay people alike. So yes, out of innocence and good intention, I think healthcare providers always have wanted to prescribe enough medication so that people don't feel like they're, at a loss if they're in pain. But now I think we're taking more pause and only prescribing what we really think is necessary with limitation. And advising a phone call or some sort of communication with the healthcare provider if you feel that more than a few days of pain medication might be necessary. So I typically will limit what I prescribe and ask patients to call me or notify me somehow if they feel that they need more. But I'm really finding that people are able to get by with the over-the-counter options after a couple of days.
Great, thank you. And we were surprised with a recent report that women are 40% more likely than men to become what was called newly persistent opioid users following surgery. And so what we mean by that is they're continuing to take the opioids 3 to 6 months after their procedure. And I think, Kim, that's what you explained as part of your story, continuing to take them. Can you talk a little bit about why do you think that is? Why are people continuing on the opioids longer term? Or Dr. Dweck, if you have a perspective, why women?
Yes, absolutely. And your story is incredible, and the fact that you recognize things. But what we didn't recognize, and which was a real wake-up call to me, is that women have a different hormonal profile than men. Okay, just like individuals have different metabolic rates, different ways of metabolizing medication, women and men may be different in the way they metabolize opioids. So aside from hormonal changes, but also just different metabolic regimens or speeds, if you will, that what men and women go through might put women at higher risk for dependence.
And for me, I think I was self-medicating because of my anxiety and depression. I didn't realize that's what I was doing until later on, but the opioids were numbing me, and they were numbing all the feelings that I had, and so I was taking them to pretty much to numb myself. And after I got into recovery, I quickly realized that that was one of the things I was doing.
No, I'm sure that's what we hear a lot from people who have, whether it's young people who've become addicted or others, that it is a self-medicating to really mask some mental health issues that we haven't really addressed appropriately either. According to the CDC, when we talk about young people's overdose deaths among millennials have increased almost 50% between 2014 and 2016. As we're all mothers of millennials or next generation of millennials, I know I found these findings really concerning. I'm sure you all did as well. What do you think these conversations that we should be having about opioids with young people, how can we help, as you said, Kim, prevent what you started experiencing and realizing, coming to that realization that you were self-medicating? How do we really start those conversations?
Well, for me, being honest and telling my story to my kids and explaining what happened to me, and just what the long-term effects of taking opioids can be. You have to talk to kids on their level and age appropriately. I don't want to dump too much stuff on them and scare them. It was, Mom had some problems and I'm better, but this is what happened, and we're going to work on doing anything we can not to bring opioids into our household.
That's great. And tell me a little bit about, I know you have a wide range of children.
Yes.
So talk a little bit more about what are those types of conversations with maybe your older children, young adults that.
Right. Well,
as
like
well.
my 18-year-old, she's going to be having her tonsils removed on New Year's Eve, and they want to give her opioids for pain relief, and I told the doctor, I said, I'm in recovery. I really don't want that in the house. And he said, well, she's 18. She can make up her own mind, but she understands my history and what's going on, and that, it really, I should be worried, to bring these in. Don't bring temptation into the home. So we're gonna try an alternative medicine, and I mean, if she needs, they can call in a prescription for opioids, but that's the last option for us.
Dr. Roth, and what would you say about those conversations and how to start that?
I feel being direct is most appropriate. I see a lot of young women in the millennial age category in my office who might even be undergoing gynecologic surgery or whatnot. And I start from a very conservative approach when it comes to pain control, and then move to a more aggressive approach with narcotics only if really necessary. And again, this comes back to setting expectations. I will say to a 16-year-old, whether or not she's sitting with her mom in the room, because sometimes she may not be, you're going to have some discomfort. I'm going to ensure that you are prepared and that you have these over-the-counter varieties available to you, in addition to some of the other complementary things, whether it's ice or heat or relaxation exercises that might also be helpful along with over-the-counter medications, and set the stage for a successful recovery without narcotics. Always knowing that I can bring that into the plan if necessary.
That's excellent. And I think being so honest about family history is critically important. It's something that you mentioned, the stigma and the shame really prevents people from having those honest conversations. Can you talk a little bit more about your advocacy work and telling your story and helping others who are facing this challenge of they may be either getting ready to have surgery and are worried about opioids or have a child, but it sounds like you were very direct in saying, we have a family history here. This is why you need to be careful. Can you talk more about what that's looked like as well?
Well, with my advocacy work, sharing my story and, getting into detail, giving them the details, really going into explaining the withdrawal, what I went through, the symptoms, for 2 weeks. I was pacing the floors. I didn't know what to do with myself, and just giving the dirty details on what it can happen with an opioid dependency. And the more people I talk to, the bigger it gets, and they can share my story with someone. Someone's going to share their story, and it just kind of snowballs.
That's great. Thank you. I know we talked about the quantity of opioids sometimes that are prescribed and what that means in terms of maybe patients who, their pain is managed, but now they still have leftover pills. In fact, almost half of 40 to 54-year-old patients had leftover pills that they keep in their homes. And we know this is the age range of high risk, not having temptation in the house, or just additionally risk associated with unused pills. What should parents do if they have pills left over in their home? How should we be thinking about cleaning out our medicine cabinets and managing those excess pills? Kim, do you want to start with that?
There are take-back programs. There are also, you can contact the pharmacies. There are home disposal products that you can use to dispose of your medication. And just leaving them in the medicine cabinet isn't an option. Right. Most of our young ones that do experiment with opioids, they get it from a family member.
Right. And Dr. Dweck, anything you could add there around, I know a lot of times people say, well, I'm going to keep it just in case. just in case I may need that later. I mean, how do you advise patients in thinking about drug disposal?
I am hoping that this is going to become less and less of a problem now that all this education is coming out and people are recognizing that we really need to be careful here. I know that in my state, in New York, when we prescribe opioids, there are already limitations set on how much we can prescribe at once, which is a very helpful tool. I also would prefer my patients call me if I would rather prescribe too few than too many and get a phone call if a renewal is needed, because I would prefer to assess their medical condition and status before just trying to put a Band-Aid over with excess medication. In regard to disposal, same. We sometimes will dispose of certain things in our office. Pharmacies in my community will dispose of medication properly. So.
Great. No, and I think that, again, just helping people change this attitude around saving it just in case, or I might need it later, and saying, this actually presents risk not just to you and your family, but to the community, and how we can take those next steps, and whether it's at-home disposal products or taking them to pharmacies, I think is an important message for everyone. We talked a little bit about, I mentioned in my story that, I tried to have this conversation with my son's surgeon before the surgery about non-opioid alternatives. And Kim, you mentioned that with your daughter getting ready to have surgery, you're kind of starting that. Let's talk a little bit about how does surgery contribute to the risks of opioid dependence and opioid addiction, and how do you start to manage some of those conversations? So Dr. Dweck, do you want to start with that?
Well, again, I think education is key. There are online resources, certainly Plan Against Pain online, the Choices Matter survey information, the CDC, and just layperson literature that's written about is going to mention this subject matter. I think that in my case, as a gynecologist, women are going to come in for a pre-operative visit, so they'll have an opportunity to present me with a list of questions that might be on their minds. I want to know, what is their general pain tolerance? Do they consider themselves sort of wimpy in the pain field or really able to tolerate? And we'll manage things appropriately. I tell them to prepare themselves, have over-the-counter medications available in their homes before they come in for surgery, so they're not scrambling to get something after the fact. Caregivers need to be on board with this. If a woman is coming in for surgery, whether it's C-section or something else, and has caregivers at home, they need to be on board with this plan. But I think the biggest information that I got from this whole campaign is something that we might have overlooked as healthcare professionals, which is that when we prescribe pain medication, we shouldn't assume that people understand that they're not supposed to take the whole bottle, okay? This was a newsflash to me. So now I make it my business to explain, you have this many tablets, you do not need to take them all, they're there just in case. I would rather you rely on the over-the-counter. So we need to do a better job in the medical field to try to really lay this out in very simple terms so people understand that.
Great. Kim, anything you'd like to add around having that conversation with a doctor?
Yes, for me, having the questions prepared, write them down so that when you go in for your pre-op, that you're not going to forget something that you may be important. Don't feel rushed when you go in either, because that's your time. Research what other pain alternatives there are before you go in, so you can discuss them and talk to the physician about them. Having an aftercare plan, ask how long should I expect to be in pain, and how much pain is, what is the normal amount of pain, because pain is okay. And that was something that I didn't understand. I thought I should be in zero pain. And having that aftercare plan, having caregivers on board, give your caregivers the aftercare plan so that they understand what your wants and needs are.
That's really helpful. And I know we have resources on our website. I think one of the most frequently used is 10 questions to ask your doctor, because it is hard sometimes. You've got so much, you're thinking about the surgery, you're thinking about other pieces, but being able to come in with those questions prepared that says, let's have this discussion ahead of time, so you're not kind of on the back end.
And your healthcare provider is going to appreciate that, because these days with such limited time, you want to make the most of every minute that you're in the office. I will also say that many practices have physician extenders, nurses, PAs, who are also available to discuss this, because these are common questions that every surgical patient is going to have, so it should be an open-ended dialogue.
Excellent. And I know, Dr. Dweck, you mentioned that you a lot of times use long-acting, non-opioid alternatives during the surgery that can kind of help people get through that first, most acute pain. How has that impacted your opioid prescribing? And do you find any differences in kind of the recovery that your patients have when you're using non-opioid options?
I find a huge difference in, number one, the nuisance factor of having to prescribe opioids. My prescription numbers have gone down significantly since long-acting analgesics that are injectable are available during surgery. I also feel that patients, especially my patients predominantly are young, healthy women who want to get back to their day-to-day lives quickly. I feel that they're able to do that. So I think it's been very impactful. And this is something that I can do in the operating room. It adds, seconds to what I'm doing, so it's not a burden, and it makes a very big impact.
Great, thank you. And this question's for both of you. We talked about education and resources. Thinking specifically, I guess, Kim, we'll start with you as a recovery coach. For those that are in recovery, how should they be thinking about and understanding what non-opioid options, if they do need to have surgery? Because I know we've heard people who want to put off surgery because they're worried about that. So can you talk a little bit about, as a recovery coach, how you work with those that are in recovery and managing when they need pain management?
Right. I have to probably have my other hip replaced, and I had been putting it off because I didn't know my options at the time, and I was not going to go down that road again. And I don't think there's enough education out there on non-opioid options. I just happened to stumble upon it, and we really need to get the word out there and educate people. And it's easy to have a one-on-one conversation with people and tell them that I blog about it, I write about it, and put it on Facebook. I try to get it out there as much as I can possibly, but there has to be other resources out there available for people to understand there are non-opioid options.
I would just love to add that I just so admire your courage to speak about this, because what I really hope for is that my patients are very honest with me in my office, because I can't take proper care of them, particularly in a surgery setting, if I don't know that they might have had a history of dependence in past. Once that conversation starts, well, then the cascade of how we're going to manage things is just so much easier. We can plan and prep, and there's no stigma. It's just a matter of fact, and we take care of it. I also wanted to note that my patients who have had dependence issues in past are the most motivated patients not to use opioids in future and subsequent procedures, because some things have to be done, and so that makes my job a whole lot easier.
Well, when I first, the day I decided that enough was enough, I called my primary care and said, do not prescribe me any more medication that could be habit forming. I had it put in my records, because there could be a day that I decide, oh, I need them. And I was doing it, looking out for myself long term. So that was one step that I had to make.
That's great. And I think it's so important, Dr. Dweck, that you welcome that discussion with patients. I think a lot of times, and there's research that we've seen where people in recovery there is that shame and stigma. They don't want to tell their doctor that they've had a problem in the past. They don't want to tell family members. So is there anything on a proactive basis that you think physicians can be doing to help start those conversations or help make it be more open?
Sure. Well, look, I think it's just a direct conversation. This is a piece of factual information about your medical past that we need to have in order to take the best care of you. I like to think that the medical profession is not particularly judgmental. We're just really there to take care of you in the best way that we can. So that's the way I would proceed.
That's great. And so Kim, as a patient who was prescribed a high volume of opioids following surgery, what lessons or advice would you share with others based on kind of discussions with your surgeon or doctor about pain management?
Well, like I said, having those questions prepared.
Yep.
And setting up your desired wants and needs for surgery, and explain, this is what I want, this is what I need, and having that aftercare plan. Research everything. I research everything now. I since in recovery, I just want knowledge. I am like, what can I do to help? What is going on out there? And if you understand the surgery you're having and what the process is, how long the recovery is, you're going to have those expectations, and you're going to go into the surgery like, okay, after day 7, I'm going to be over the hump, or you're going to understand and have going in blind and not knowing. That's when you're like, oh, when is this pain going to end? I need more pain meds because I don't know when it's going to end.
No, that's so important. Managing those expectations. I think we've heard that over and over again. If you set expectations up front, you know what to expect, it really helps you feel much more in control of what's
I
gonna
also
happen.
like to discuss the negatives that are, maybe not as crucial as dependence, but that are uncomfortable. For example, you're having a C-section, your bowels may take a little bit of a hit for a short period of time. Narcotics are going to constipate you. This is miserable. Women don't want to manage that. Right. So that's yet another reason to try to avoid or minimize. The grogginess factor is a big deal, especially for young, healthy people otherwise who don't want to be knocked out. So I try to focus on that side of things as well.
Very helpful, thank you. And are there any signs that, if we think about the caregivers and family members, we've talked about the importance of them being involved in the plan. What should caregivers or family member be looking for in terms of potential dependence or leading to addiction to opioids? Any signs or symptoms you'd recommend people look for?
Taking their medication more than needed, running out of the prescription before the time is due, irritability, there are changes in their social behaviors, they may be withdrawn, sleeping more, sleeping less. I don't know if there's
Agree
anything there.
100%.
Yep.
On my end, I think electronic medical records have made it very easy for us to see how often people are calling in for renewals. We have a system to check when is the last narcotic prescription that was provided and by whom throughout the state. So we have a check and balance system in that regard as well.
Great. And we've talked a little bit in this conversation. I know it's an important topic at Shatterproof and the work that we're doing around really helping to reduce or shatter that stigma of addiction. What do you think, Kim, is one of the greatest misunderstandings that people have about opioid addiction or dependence? And kind of how are you helping address that as a peer recovery coach?
Well, for me, before I became an addict, I thought of people, they're having a good time, they don't have any cares in the world, they have no responsibilities, and then it happened to me. And I realized that it can happen to anyone, any social class, it doesn't matter if it's gonna grab a hold of you. And there was a hierarchy for me. It was the drugs first, and then food, sleep. That I was so hyper-focused on that drug. When am I gonna get it? Do I have enough? And I wanted help for a long time, but I was taking those drugs just to maintain and not be sick anymore. And keeping the dope sick off, So I would just kept taking them to maintain, to keep myself okay. And that was my lifeline. Those drugs were my lifeline. And to ask for help, you're saying, take away my lifeline, take away the one thing that is gonna keep me from being sick.
And so how do you help people who are struggling to get comfortable in that stage of ask for help? Or is it friends and family around them? What would you recommend to others that are in that situation as you're working with them?
It's, you can't push someone into recovery. You can't, confrontation and confronting them can back the addict up and put up their defensive mechanisms. And there's stages of change, and they have to have that desire and readiness and just the willingness. And everybody has to get there at their own point. And you can't force recovery on anybody. And recovery is something that, it takes time and patience, and there's going to be setbacks.
Yep. And I think you made a critical distinction when you're talking about this is a medical illness. As you became dependent, this was, you said, taking over in your hierarchy of kind of what was important to you. And being able to look at this as a chronic brain disease, it's a chronic illness. Relapse happens, recovery is possible. You're a great example sitting here today of what a life of recovery looks like. But too often we think of, as you said, those stereotypes about these are bad choices, or this is happening to a certain type of person. So I really appreciate you kind of sharing that perspective and helping people think through that recovery is possible. And you work day in and day out with it, right?
I say setbacks can become comebacks.
Great saying. So as we're wrapping up some of our questions, what advice would either of you have for patients that if they need to have surgery, whether it be a patient, as you said, who's in recovery, or just any patient who's having surgery? How can we kind of summarize what we've talked about today for everybody that's following us? Do you want to start, Dr. Dweck?
Sure. I think arm yourself with knowledge. That's the most important thing. There's no question that's unwelcome or too silly to ask, and I think preparation is key. I think managing expectations, and just back to the millennials, these are people who feel invincible, okay? This concern can occur to anyone, anywhere, anytime, and so it really doesn't discriminate, and I think thankfully it's on the radar now, and we're much more willing to discuss and hopefully prevent it from ever starting in the first place.
Going in and asking for non-opioid options first and foremost. And that was something that, my surgeon didn't recommend. It was the opioids, and now there's a shift, and we're trying to make changes. But first and foremost, ask for non-opioid options.
That's great. Well, thank you both. I really appreciate your discussion. We're going to open it up now for questions that those of you who've been following along on Facebook, if you want to join in the discussion, we'd welcome those questions also. And so the first question that looks like came in is, if you needed, I guess, Kim, if you needed another surgery in the future, what would your game plan be for managing pain after surgery?
Well, for the possible next hip replacement, there are blocks that you can have, and they can last up to 2 or 3 days without any pain medication. And then after that point, you can take Tylenol or over-the-counter medications, and also other alternatives, physical therapy, massage. There are so many different alternatives out there that I'm finding, chiropractic, that there are other options out there besides taking pills.
Great. Anything you'd like to add to that, Dr. Dweck?
No, I think your answer is, you have the benefit of hindsight.
Right.
Yes.
And so you can use that for your advantage, and I think most people can. And go in with your eyes wide open. That's the most important thing.
Excellent. Another question, a message based on your experiences, kind of what's the one message you'd like to leave attendees with or participants with today?
Well, I think I mentioned before that this is something that could happen to anybody, and so I think nobody should have a blind eye to the usual first entry place to a narcotic, which is surgery. So go in eyes wide open.
Yes, and have that conversation with your physician about your options. Don't just accept what they're giving you. Question it.
Well, and I'd like to just take this chance to say that I think healthcare providers are becoming much more well-versed in this. It seems from the studies and surveys that are done that there are a fair number of people who truly just rely on their healthcare provider to say, do this after surgery. And while that may be appropriate for some people, we need to, as a healthcare community, be able to provide the right advice, which is narcotics should be minimized, if not avoided altogether, and the alternatives be presented.
Excellent. Well, thank you both so much. I think that's all the time that we have for today. Thank you, everybody who was able to join us in this conversation. If you want to have more information, I know we threw out a lot of statistics, a lot of questions you could learn about or ask your doctor. You can visit shatterproof.org/choicesmatter. It has our 10 questions to ask your doctor. It does have information about non-opioid options and ways that people can learn about this. So again, thank you everyone. I really appreciate both of you taking your time today and sharing your stories with us.